So, I want to start with a story that isn't rare. It's almost pretty ordinary. While thinking about this assignment, a few things kept popping into my brain. So, a senior has an injury or a surgery that technically goes well, and the hospital does what it can do. The incision is closed, pain is managed, the scans look okay, and the chart starts to say the words that everyone waits for, which is medically cleared. And then the real questions arrive. They're going home with a wound that needs care. They need dressing changes, maybe injections, maybe a walker they don't have. They need help showering safely. They need someone to check on them. They need a PSW or nursing visits or both. Public home supports exist, we all know that. But we also know what it feels like when the support you need is not the support you can reliably count on, especially when staffing, scheduling, and scarcity shape what available means. So the family starts doing math in the same breath as they're trying to do care. How many hours can we cover? Who can take time off work? What happens if we can't lift them safely? What happens if we can't afford what isn't publicly covered? And suddenly, discharge planning is not a plan, it's a negotiation with reality. My name is Brittany June Gamble. I'm an Anishinaabe social work student, and I'm doing my placement at Juravinski Hospital, mostly working with older adults in the emergency department. So this episode is about discharge planning, but not as paperwork or logistics. I've come to understand discharge planning as the place where the social welfare system shows itself, where the line between provincial healthcare and community life turns into a very real question. So here's my thesis. Discharge planning is one of the clearest sites where social welfare policy becomes a lived experience, and social workers can go beyond responding to that reality and help shape how it gets enacted. So that idea kind of lines up with how our class framed frontline workers as the human face of policy with real discretionary power and how policy gets experienced on the ground. And I'll be honest, it's hard to hold on to in the hospital culture, especially when burnout turns everything and everyone into survival mode. Before this course, I understood policy as something that lived in documents, legislation, budgets, mandates, and I knew it mattered, but it still felt like it belonged to boardrooms and government buildings. But this course and my placement has forced me to admit something that I have always felt in my body, but I couldn't name, that policy is intimate. It's not something that's distant from us that we can't control. It's not something that trickles down to us from some messages above. Policy shows up as who gets time, as who gets believed, as who gets described as non-compliant, and who gets discharged. And most importantly in this talk, is what home is assumed to mean for individual people. So for example, I can think of the kind of patient who gets described as non-compliant because they miss their follow-up wound care, but once you slow the story down, what you actually see is somebody who's living alone. They're trying to stretch a limited and very fixed income. They're struggling with swelling and pain. They need multiple bus rides to get to appointments. They don't have someone to help carry supplies or even get safely out of the door. And in their medical chart, that can shrink into a few simple words like missed follow-up or poor adherence. But in real life, that's not just a person's behavior. That's the consequences of policies sitting inside of a body. In lectures, we talked about street-level work, the idea that policy is not only written by decision makers, that it's made through day-to-day actions and decisions of workers on the front lines. So when the assignment asks whether social workers make, shape, and enact our organizational, political, and policy context, my answer is not a clean yes or no, but my answer is we can. Not because we're all powerful, but because we're the ones standing in the moment where a policy becomes a person's actual life. And the reason I can't give a simple yes is also real. Colonial institutions exhaust people. Scarcity exhausts people. Hospital pace exhausts people. So the question becomes, how do we stay awake enough to keep acting like policy actors when the system trains you to go numb, essentially? Here's the fault line that I want to name clearly. In Ontario, municipalities are one of three orders of government, and the Association of Municipalities of Ontario, or the AMO, describes municipalities as the order of government closest to the people, providing services that impact daily life. AMO also explains that municipalities operate under provincial legislation and that Ontario has made many social services like social housing, shelter services, and childcare a municipal responsibility. And AMO notes a major reality that shapes everything, that municipalities rely heavily on property tax as a key revenue source, which very much limits what they can do and how far the dollars can stretch. So when a hospital says medically cleared, what I often hear underneath it is that the healthcare system is done with the part that it can fund quickly. So the rest of the work, which is safe housing, food, transportation, home supports, caregiver capacity, it all has to happen in the community. And sometimes that looks like an older adult who's medically cleared, but they live in a home that was never built for recovery needs. So their bathrooms upstairs, the bedrooms upstairs, the hallways are narrow, there's no grab bars for aging needs or recovery needs, no one to help with transfers, there's no family members who can suddenly become simultaneously a porter, a nurse, a meal provider, and a driver all at once. They may not qualify for long-term care. They might not have money for the private supports, and even if they are eligible for something publicly funded, eligibility is not the same thing as immediate access. So the discharge can look very reasonable on paper while feeling very dangerous in practice when we're sending them out the door. And discharge planning becomes the bridge between orders of government, and that bridge is where people have to fill the gaps. And there's a reason that this hits so hard in geriatrics, because older adults often don't need more medicine, they need more supports, and they need conditions that make recovery possible. So Sherry Torjman and Charlotte Leviton Reed, in their work on the social role of local government, describe local governments as service providers involved in things like childcare, social assistance, public health, community supports. And they point out something that matters for discharge planning. Even where evidence supports integrated, holistic service delivery, the services are still often organized in very discrete categories like public health, primary health, long-term care, school supports, childcare, social services, housing, social assistance, etc. They also make the point that integration doesn't always mean merging departments. Sometimes it means improved coordination. But in practice, coordination often means somebody has to hold the map, to know how to navigate, to coordinate. And when the system isn't resourced for that kind of coordination, the map ends up in the hands of the people who are already exhausted. And that map gets complicated very quickly. So one discharge can mean figuring out whether supplies are covered, whether home nursing will actually start in time, whether there's anyone available to help with bathing or dressing changes, whether the person can physically get to follow-up appointments, whether they can afford transportation, whether medication management is realistic, especially when vision or pain, mobility, or a patient's cognition are all changing at once. And none of this is extra stuff. That's the actual architecture of a safe discharge. And when no one system is really responsible for holding all of that together, the burden quietly shifts onto families or onto the patients themselves who are already unwell. So, my bigger thoughts on this topic. On the outside looking in, the gap between medically cleared and safe to go home can look like a sad accident, but this course has helped me see that this gap is quite structured. Stephen Hicks, writing on the history of social welfare, shows how long we've been sorting people into categories of deservingness. He traces how poor law thinking framed some people, like older adults and disabled people, as deserving, while others were treated as less worthy. And he also traces what happens in an era of erosion like we're experiencing now, deep cuts and restricted eligibility that reshape what public support looks like in everyday life. And in the hospital, you can literally see the erosion in the cramped hallways of emergency, sometimes even on medicine floors. HW is the code that the hospital system uses for hallway beds. And that's not just a capacity issue, that's a policy story that's been made physical. So when we act surprised that families are absorbing the burden, we're sometimes forgetting the long story that a social welfare system that repeatedly narrows who gets help, how much help, and under what conditions. And this is not only true in geriatrics. You can see the same structure in other kinds of hospital returns too. So think about someone living with diabetes who's repeatedly described as non-compliant, but who's trying to manage insulin while dealing with poverty, unstable housing, food insecurity, homelessness, and proper diet becomes almost impossible. The blood monitoring supplies cost money that often aren't covered, and require out-of-pocket costs. Transportation to wound care clinics, which is common for diabetics, especially those who have precarious living situations. The transportation to the wound care clinics for them, it's not simple. Appointments are much harder to keep when their survival is already full-time and more work. So then they come back to the hospital sicker, sometimes in kidney failure, more infected wounds, sometimes needing amputations, which require a whole different type of treatment and rehabilitation that, living outside can't accommodate. And sometimes the language of personal failure really creeps in to things like their medical chart, to things like the conversations that we're having with the patients when we're discussing how they need to care for themselves better. And we're doing all this while the policy failures remain unnamed. This is where I want to drop a line that I'm kind of carrying through the episode, is that every discharge plan sounds reasonable until it meets the reality of cost, labor, and more often than not, a home that is not designed for recovery. And there's another discharge moment I keep thinking about, because it's not dramatic in the way people expect, it's more quiet. A caregiver is sitting beside the stretcher. They're polite, they're organized, they have a notebook with medications and dates. They're the kind of person that the system loves because they've been doing the work that the system doesn't fund. And as discharge planning starts, home supports, wound care, mobility, safety, they don't interrupt the conversation. They just nod and they ask super practical questions. And they do what we reward people for doing, staying calm. But at some point, the caregiver says one sentence that changed the whole room. I can't do this anymore. Not I don't want to, not I'm refusing, just I can't. And you feel the shift because that sentence breaks the illusion that home is automatically a safe plan. Like the air changed and the conversation stops being clinical, starts being honest, and home becomes a question instead of an answer. In this instance, home is not just a door you can close behind someone. It's stairs and bathrooms and meal prep and medication schedules. It's a body that can't do what it used to do. It's waking up in the night confused and needing help. There's transportation and follow-up appointments, wound care supplies, and the very tiny administrative miracles that keep someone stable. And tucked inside the word home are assumptions we don't always name out loud, that someone is always available, that they have the time, that they have the money, that the space is safe and accessible, that they can lift and drive and translate and advocate and be on call without breaking. And when the caregiver says, I can't, the system loses its invisible scaffolding. And suddenly the discharge checklist looks different. Like it was built for a life that only exists in theory. Because if the only reason home works is because one person is quietly holding everything together, then that wasn't safety. That was simply one person's endurance. And when endurance runs out, go home starts to sound less like a plan and more like a transfer of risk, sort of storing danger in private homes and calling it community care. And the system starts looking for somewhere to put all of the weight. But oftentimes the honest answer is it will not happen quickly and not enough, and not in a way that matches what this person actually needs for healing. And that's why we need to remember caregiver capacity is not infinite. It is not a natural resource. It is labor that we treat as free. And we have built policy assumptions around that assumption. And that is discharge planning as social welfare. So when I hear that sentence, I can't do this anymore, I'm reminded that discharge planning is not just a clinical decision, it is a jurisdictional one, and it is a policy one. And that means my social work role is not neutral inside of it. And this is where some of the course material gives me more language. So DeCourt and Roos describe how, from like a bottom-up perspective, policy is produced through administration. Frontline workers end up shaping how policy is experienced because we interpret rules, we navigate the constraints, and we make decisions in real time. And they also frame social policy as an open-ended democratic practice with a strong normative dimension because scarce resources are allocated among competing needs, and that allocation is political. So when I'm discharge planning, I'm not just arranging services. I'm standing at the point where decisions about resource allocation become real. And the choices that I make really matter. So what I name as the problem and what I document, how I document it, what I treat as urgent, what I refuse to reduce to non-compliance, and especially what patterns I track across the cases. In burnout, that can be hard to notice. I think documentation is one of the clearest examples of how frontline workers can shape policy experience. So on one hand, you could have a note that says, daughter is reluctant to take patient home. But on the other hand, you can have a note that says, daughter reports inability to safely provide transfers, overnight supervision, wound care, meal preparation, and transportation to follow up without formal supports in place. And those are two very different stories. One makes the family sound resisted, or the other reveals that the plan very much depends on unpaid labor that's already well beyond capacity. So even just our wording can either individualize the problem or actually tell a full picture truth about the conditions that are producing the problem in the first place. Heck, even the language that I use can either hide the system or reveal it. And this is where our course discussion of moral distress really hits, like the political anguish of knowing the ethically correct course of action, but being constrained by those institutional realities. Because discharge planning often asks social workers to solve systemic scarcity with interpersonal skill, and that's where the ache lives. I can't talk someone into being happy about not having anywhere to go when they leave the hospital. So I guess this is also where professional ethics show up. The Canadian Association of Social Workers' social policy principles make it clear that social work is not only about individual helping, it's about social justice, equity, and addressing systemic causes of harm. So if I act like discharge planning is neutral, I'm not being professional, I'm actually participating in erasure. And I also can't talk about social welfare in Canada like it's neutral. Go back to the TRC Call 57. It explicitly calls on federal, provincial, territorial, and municipal governments to educate public servants on the history of Indigenous peoples, the legacy of residential schools, UNDRIP, treaties, Indigenous rights, and overall anti-racism. and the national inquiry into missing and murdered Indigenous women and girls is very explicit that all governments includes municipal governments. The inquiry defines a decolonizing approach as resisting and undoing colonialism rooted in Indigenous values and knowledge systems, making space for marginalized Indigenous perspectives. So for me, discharge planning is never only a hospital workflow. It sits inside a larger question: who gets safety and what kind of safety counts? Because if safety is defined only as baseline function or not dying today, the system can congratulate itself while sending people back into conditions that quietly shorten their lives. A decolonizing approach pushes me to ask different questions about dignity, about relationship, and what it means to actually sustain a life. So for me, this also means questioning what the hospital assumes home means. And home is not automatically safe just because it is familiar. Home can also mean overcrowding or isolation, inaccessible space, the poverty, family members that are already caring too much, or mistrust of systems that have harmed people before. And as an Indigenous social work student, I cannot pretend that people meet healthcare as blank slates. Colonialism has already shaped whose pain gets believed, whose family structure gets read as capable, and whose survival strategies get misunderstood. So a decolonizing discharge approach asks more than whether somebody can technically leave the hospital. It asks what kind of conditions they're being returned to when they leave, whose labor is being relied on, and whether the system's actually supporting their life or just kind of offloading that risk back into the community, which often just seems the patient return again, and this same cycle that I'm talking about keeps repeating. So what do I do with this beyond just naming it? First, I have to target the right level of government with the right ask. The Ontario Nonprofit Network's advocacy toolkit is clear that different orders of government handle different issues, and advocacy has to match the level of decision-making power. Second, I keep trusting that frontline knowledge belongs in policy conversations. Maitre argues that frontline workers understand on a granular level how policy creates barriers, and that policy work needs to meet frontline reality because real life is messy. And Maitre's 5 Good Ideas makes the point that frontline workers are deeply connected to how policy gaps become harm, yet we are often excluded from the political conversations. So in discharge planning terms, my advocacy practice would look something like, on the micro level, naming the real issue in the room, like this is not a motivation problem, this is a support problem. On a meso level, I'd be tracking patterns across cases, bringing these themes to teams and supervisors and quality tables, and then building relationships with community partners so that discharge isn't a lonely scramble. And on the macro level, pushing municipal and provincial accountability differently. Municipal supports like housing and local service coordination, provincial levers like home care capacity, long-term care policy, and discharge pressures. On the micro level, that might mean saying while you're in the room that, this is not a motivation problem for the patient, this is a support problem. The supports that they don't have in the community or they don't have publicly available. On a meso level, it might mean noticing that we keep seeing these same kind of returns. So the older adults are going home without enough help. The caregivers are collapsing under the impossible expectations. There's people being labeled difficult when the real issue is structural scarcity. And on the macro level, it means refusing to treat those patterns like isolated bad luck and continuing to move on to the next situation and going, oh, this sucks, which is something that I see often. It means naming them as predictable outcomes of underfunded home care, of the housing precarity, the downloaded municipal responsibility, and an overall provincially run healthcare system that too often measures success by discharge speed rather than by whether the life is actually supportable once someone gets home. And I'm going to say something blunt. Policy is not an extra hobby, which is something that I've noticed in conversation with peers in this field, adjacent fields, at my placement. It's not a hobby. It is a part of the practice. The system contains much of our practice within policy guidelines, which makes policy a direct part of our daily work. I want to bring in Ruha Benjamin here because this line feels like it was sort of made for municipal provincial realities. Benjamin writes that viral justice can be found in the small print of city, state, and federal budgets. And it's truth. Budgets are moral documents because what we fund is what we value, and what we underfund becomes a private burden. And what we call family responsibility is often just a dressed-up way to frame public abandonment. So how do I do this work without going super numb? Our lecture on critical hope was good. Hope was framed as action-oriented, not just a feeling, which is something that I think I'd need to work on here. It's something that grapples with political, emotional, and relational dimensions needed to enact change. And it gives me a line that I keep coming back to. Critical hope is not something you have, it's something you practice. So in discharge planning, critical hope might look like not pretending that the system is enough, that it's practicing truth-telling that turns the patterns I see into evidence. It refuses blame-based narratives, and it keeps pushing responsibility back toward the structures that created the gap in the first place. Because discharge planning will break your heart if you think you're supposed to personally fix what was structurally designed. So critical hope lets me stay tender without being naive, and it lets me keep naming the system while still caring about the person in front of me. So I'll end where I began. In the end, discharge planning keeps revealing the same truth. The plan is only as real as the supports behind it. And right now, and I think that's the part I keep learning in placement, that a discharge plan can sound clean, it can sound organized and professionally written, and still very much depend on invisible miracles. It can depend on a daughter who's already missed too much work, or on a neighbor who checks in unofficially, or on a fridge being full when there's no money. On stairs that somebody's pretending they can still manage, or on a body that's much weaker than the chart can admit. So when I say that the plan is only as real as the supports behind it, I mean that some plans are not really plans at all. They are hope attached to scarcity. And I'm left with questions that feel alive in my practice. What would it look like if discharge planning was resourced like it mattered? And if going home wasn't treated like a private miracle, but a public responsibility? And what would it look like if municipalities had the tools to meet the needs that we keep pushing onto them when they're already expected to deliver so much with constrained revenue as the AMO laid out? And what would it mean for me as an Indigenous social worker to keep practicing a decolonizing approach inside institutions that were not built for it, especially the way the MMIWG inquiry calls us to think about accountability across all governments? Because I'm learning that this gap isn't a mistake, it really is a structural design. And my work is not only to help people survive it, I need to keep naming who built it, who benefits from it, and how not only I, but we collectively as social workers, allies, and everyday people can change it.